We did this as something that was integrated into the protocol, so we want to use this as a prospective decision tool. And on the ongoing ARIEL2 trial, that's exactly what's happening. So we've now going to be stratifying these patients on the basis of their genomic score, their loss of heterozygosity score, and the BRCA mutation status. And with that predictive biomarker now integrated into the trial, it'll help to move it forward. And then we're also going in this particular program, we're going to expand the ARIEL2 trial to allow for a little more heavily pretreated patients that didn't quite fit this platinum-sensitive cohort, and see how the drug performs in that patient population. Again, trying to understand how this biomarker helps to discriminate patients. Now, I'd love to say it was perfect, right? You'd love to have the perfect biomarker, 100% response when it's there, 0% when it's not, and we clearly are not there. Even patients who carry BRCA don't respond 100% of the time, and the question is, why not? So it always can be improved, and so we're going to go back and we're going to look in that cohort. Again, try to see if we can tweak the model, come up with a better algorithm. I think it was really telling, and we reported on it here, was that if you look at the BRCA wild-type patients who had high degree of loss of heterozygosity, not all of those genes that were aberrant actually translated into response. So we know that not all of the genes that are involved in the pathway for homologous recombination are actually representative of a synthetic lethality situation, which is what we expect with the BRCA genes. In our report, we saw essentially a gene such as RAD51C, where we had a pretty strong response characterization in that, but other genes that are in the pathway didn't see a response. So we'll continue to try to tweak it and move forward from there.